Nick Majerison here. Welcome to the TopMedTalk Top 10. This series is a chance for new listeners to jump on board and for established listeners to catch up on some of our favourite podcasts so far. In no particular order, we are giving you our top 10 most downloaded podcasts. It's EBPOM 2018, the Roundtable on NELA and Shared Decision Making. It's presented by Desiree Chappell. Have a listen.
TopMedTalk.
So welcome to day 2 of EBPOM 2018. I'm Desiree Chappell, host of TopMedTalk, and I'm joined this morning by 2 very special guests that were part of the presentations this morning. I'll introduce them in just a moment, but it is another beautiful day here in London, and another exciting day of fantastic content. And today is a special day in celebration, and really important to many of the delegates that are here at EBPOM. We are celebrating 70 years of the NHS, so very, very cool. So to introduce my guests, we have the presenters from the first session. We have Angela Coulter. She is a UK-based health policy analyst and researcher, and she really has a passion for engaging patients and the public for their own health care. And Angela, I loved your talk on shared decision-making. That's what you're talking to us today, which is definitely a challenge for sure in implementing that into practice. So I look forward to discussing that with you. Thanks for joining us this morning. And our second special guest, we have Hare. She opened the day with a fantastic topic, and we've heard a little bit about this, the NELA, or the National, Sarah, what is this? Remind me.
It's the National Emergency Laboratory Audit.
Right, that's right. It's an audit. And we discussed that with Carolyn Johnston a little bit yesterday in one of our podcast discussions, and she was the improvement lead for NELA. And so, Sarah, you are the clinical lead for the Royal College of Anaesthetists, right, in this project. And you're also a consultant anaesthetist at Medway Maritime Hospital, yeah? Yes. Thank you, ladies, for joining us this morning. So back to the NHS and celebrating 70 years. Sarah, you are now a provider in the NHS. So did you hear Sir Bruce Keogh yesterday give his plenary about celebrating the NHS?
I did, and I always enjoy hearing him talk, actually. And he said some really important things that resonated. So I work at a hospital called Medway Maritime Hospital. And as I was mentioning in my talk, it's a hospital that's a very special hospital, that it's been in special measures. Or it was in special measures, one of the longest of any of the hospitals.
And with special measures, what does that mean for non-UK?
So Bruce Keogh, he initially reviewed the hospitals' performances that were underperforming, and he found 14 hospitals that weren't doing so well, and they were called the Keogh Trusts, and they had to do something about their mortality and all sorts of pathways and processes of care. And this Care Quality Commission are a group, a body that come and inspect hospitals and will benchmark you on quality of your care that you're delivering or providing. And we were a hospital that was hugely struggling, and despite having members of staff who were caring. So even though we were in special measures, which meant we were underperforming, we were always performing when it came to caring. And something that Bruce said really resonated, and it was something that our own chief executive says, is that we undersell ourselves. So those staff who were working in really extraordinarily difficult times, being a hospital under such focus and being told that you are poorly performing is difficult. And nobody wants to come to work somewhere where they're being told you're not doing a very good job, actually, because actually every single member of staff came to hospital to do a good job for their patients and care. And what he said about not underselling yourself, about celebrating the good stuff, was so important, and something that our chief exec and our teams are trying to do. You know, yes, we were a hospital in special measures, but we're not out of special measures. And there is some great work coming out of your hospital, and there's great work in caring for your patients and improving outcomes for them. So that really resonated at a time when things are tough and it is difficult. Actually, you care as a clinician, as a nurse, as a doctor, and you're doing a great job. Celebrate what you're achieving and keep doing it. And then our responsibility with projects like NELA, with the colleges, is to put in place tools, pathways, processes, systems, whatever you might want to say, tools to enable the staff to do the job that they come to work to do, so that when we walk into a room, we enable others to do the best of their abilities to do good stuff for their patients. So it resonated a lot what he said.
Yeah, and sometimes you do need to take it back to that basic level of we're here for the patient, we know we're caring individuals, and then do the gap analysis of, okay, where are the places that we are missing, and what can we do to improve that? So NELA is this quality improvement program. Did it start out as that, or what is the history of that?
So NELA came about after, or NELA or NELA, depending on who you talk to, National Emergency Laboratory Audit, came about as a result where we wanted to understand more about what care patients who are having emergency laparotomies were getting. So when they came into hospital, what happened to them? And initially it did start out as an audit project. It looked at some national standards, and then NELA would audit against those. And we would do quality assurance around that. We would say in a RAG rating. So you're doing this well, you're not doing this so well, you're not doing this at all, or how many times are you doing it for each hospital level. But slowly it is now moving, or now less slowly, full pelt with a great team at the Royal College. So it's a full project team. We met Caroline yesterday, Dave Murray. There's a whole team of clinicians. We have a surgical lead to move towards quality improvement. So using national data at local level, making it meaningful for local teams to drive their own change programs. So we'll train people in quality improvement. We do regional workshops now. And we give people the tools and the data to make change locally.
One thing I thought was interesting is that you have all this national information, and that happens in the U.S. a lot. We have all this big data and national information, but how do we use that on a local level? So I heard you talk a little bit about bringing that down and using that information in real time to affect quality improvement. So has that worked for you all in your facility? Is that something that you're
It really has.
On?
When Medway started its journey with NELA, we were almost an outlier in our mortality. So it wasn't just the hospital that was in special measures, measuring HSMR, whatever you might use as your measure of inability to deliver care in some way. We were an outlier for mortality for laparotomies as well. But by using that national data, so bringing it close to us, it was stopping just being something that sat at high level with our medical director and the board. By bringing the data down, and so that we owned it as local clinicians, our surgeons owned it, our anaesthetists owned it, but not just that. Our nursing staff in the operating theatres understood it. Our ODPs were a part of it. They understood their own data. It became theirs. That was one of our drives. Once people own their data, then they're going to be much more likely to do something about keeping or getting it to a good level. Yeah. And then the rest of it comes naturally.
Yeah, that's the engaging part and getting them. So one of the topics that what you primarily were talking about in the guise of quality improvement was bringing the patient in and making them part of that process. And Angela, we're going to talk to you in just a moment about shared decision making, because that's part of this process. But what have you learned from your experience in NELA and working with patients and letting them help guide what their pathway looks like?
So some key parts to getting patients involved. First of all, they need to understand what you're asking them to do. Mm-hmm. We need in emergency laparotomy patients and patients who've been critically unwell to understand when we can ask them to be a part of that process as well, and then support them to be able to do that. So that we're not just consulting them, we're also using their expertise, the patients as experts, to understand which bits of the pathways and processes need to have some change.
Yeah, so Angela, I guess this comes back to you, because they have to understand first what the decision is that's being made. So you talked today about shared decision making. That's something that you seem very passionate about, and I love that and came across today. So tell us about kind of how that journey started for you, and then how you are teaching others to do that in practice.
Well, in fact, it started from the same point, actually, looking at data and trying to understand variations, and understanding that variations in the way, for example, common operations, huge variations between countries, but also within countries, in the way these common medical procedures were performed. And thinking about that, if the cause of the variations, clearly there are multiple causes, but one of the causes is different preferences among doctors. Mm-hmm. Well, if doctors have different preferences, well, then also patients have different preferences. And does it really make sense, was the question we asked, does it really make sense if the likelihood of you having a common operation like a cholecystectomy or a hysterectomy is based on just the doctor's preference? Where are the patient's preferences in all this? How can we bring it together, bring it into the decision-making process? So shared decision making became the kind of next step. What is it, and how can we make it happen if it's a good thing? So we did a number of studies, and we found that if patients were well informed about the options that they faced, understood the benefits and the harms and the uncertainties surrounding many medical procedures, and if they were involved in a good conversation with a clinician that they trusted and who was able to provide them good, reliable, evidence-based information to support decision-making, then patients really wanted to be involved and indeed benefited hugely from being involved. So the next step was to say, well, okay, how can we make that easy? And one of the ways we can make it easier, it's not an easy thing to do, but one of the ways we can make it easier is to package the evidence-based information into a decision aid, which can be used as part of the consultation or separate to the consultation, depending on, people's predilections, really, how they like to receive information. And to make sure that they have the information in a way that they can understand, that's comprehensible to them. And that means, people with a range of abilities. So we developed decision aids, we tested them out, we learned a lot more about how people understand risk and probability and so on. And we then carried out randomized trials, and indeed this is an international effort. This is going on, going on in a number of countries. And we were able to sort of demonstrate the benefits of this approach, also understand what we didn't understand, what needed more work, and start to bring it into real life, into the mainstream clinical practice.
Yeah, I have this conversation with colleagues quite a bit, and being involved nationally with enhanced recovery and some of these other projects, quality improvement projects, where you're trying to communicate. Health literacy is a key topic that we've been discussing. And one of the points that you made is who most benefits from shared decision? Is it from the shared decision-making process? Is it people with greater health literacy or not? And I found that fascinating, actually.
It is fascinating because many clinicians think, oh, well, this is all very well for our most advantaged patient, the people who have higher degrees, and they can, because after all, our patients haven't been to medical school for 10 years and but in fact, those people do benefit, but in fact, the people who benefit most, if you can get the communication right, are the people with the lowest levels of health literacy. And we've really seen improvements in understanding, in ability to get engaged in decisions among those people who you might be most surprised about.
Yeah. So one of the questions that I have is the tools, the decision tools. I heard a lecture by a nurse coordinator for an enhanced recovery program, and she was talking about, you can have papers full of words to send home, but whoever really reads those. So pictorials are great. Is that something that you're implementing, or how
I'm working at the moment with a hospital in Denmark, in southern Denmark, that it's an academic hospital, and there's a design school. A local design school. And they're doing wonderful work with designers who are using infographics. Yeah. And so they've managed to produce decision aids for patients that hardly have any words, but have lots of pictures and getting to the real nub of what people need to know if they're going to make an informed decision about their care. So that builds on an awful lot of research with patients, asking them, well, what's most important to you? And seeing how they react to the evidence, because it's no good just giving them a systematic review and saying this summarizes everything. You need to boil it down more for people so that everybody can understand.
And that's really important in emergency patients, because when we have spoken with our emergency laboratory patients, this is really early work. There's not much about decision making in time critical periods, because we get trained how to do that as anaesthetists, but you can't train a patient how to make a decision really quickly. No. So when we've spoken with them and we get them to edit and write and tell us what they want, the patient information leaflet, which we thought was fabulous, was very long. It talked all about nutrition and all sorts of stuff. But actually, it was useless for them when they first came in. So big pen strokes through it by our patients. We haven't got the infographics quite looking beautiful yet, but they wanted a roadmap. Mm-hmm. So when they came in, they wanted to know, this is the start, this is the finish going home. On the way, what happens. They said a roadmap. Yeah. So that's what we're working on designing, so they can look at it in a glance, in that time-critical moment, to understand what's going to happen next.
Yeah. Some of the best tools actually are just one side of paper.
Yeah.
That you can put on the desk in the clinic and just talk through.
Yep. Yeah. And the communication part of it, one thing that I find interesting as I've consulted patients myself is, do they truly understand what you're trying to tell them? So the feedback, getting that feedback for them, because I have so many patients that you're like, you need to do this, this, and this, and what do you think about this? And they just sit there and nod. Oh, yeah, I understand. And the families over there, nodding their head, they have no idea. So how is that something that you tackle whenever you're teaching people in this space?
Yeah, that's a key issue. One of the things that the strategies that's taught in training courses is to help people to teach back. Mm-hmm. So the clinician may say, this is what we've been talking about. Just tell me what you understand about this and what you take away from this. Yeah. Getting the patient, really inviting the patient to say what it means for them. And then that gives you a hint about whether they've really understood or whether they need a bit more discussion.
Yeah. I think that's dropped a lot too whenever you're under time constraints. You may be going and you may have this great roadmap and everything, but in the end, is it they truly understand, and a nod yes is not always the case.
And that sometimes it's interesting to look. So with NELA, when we audit and benchmark hospitals' performance, for example, in preoperative risk assessment documentation of that, the hospitals are all improving. Nationally, this is improving. This is great. We're starting to think more about risk of our patients. But it was so stark when we were doing one of our workshops and focus groups with our Survivors Club, our emergency laparotomy patients.
I want to talk to you about that in just a minute.
when the couple, when we were talking about risk, and they held hands, they didn't realise. The patient said, I didn't realise that I could have died. Yeah. So we might think we're doing a good job, but until it translates to the patient's understanding what's happening, then it's not quite good enough.
Yeah. So let's talk about this focus on the focus group, the survivor group. You mentioned that one of the ways that you were able to support patients and bring them into the decision-making process and post-operatively as well, still keeping up with them, was creating these focus group. Can you tell us a little bit about more about that?
So traditionally, support groups, focus groups, engagement has been around more chronic conditions, more established conditions, the ones that are in the public eye. Emergency laparotomies, there's no charity for emergency laparotomy patients. No one runs a marathon for laparotomy patients. In fact, most of our patients can't even say laparotomy, and they mumble it because they don't know how to say it. So we recognise that this was a gap, but how do you find the patient? And NELA is the perfect tool because every hospital is looking at every emergency laparotomy patient. So we just felt there was a gap, and a group of us, surgeons, anaesthetists and junior doctors, decided we were going to do this. So working together with our patient experience team, because we hadn't run anything like this ourselves before. Actually, as anaesthetists, we often only talk to patients very briefly, and we may not have long consultations with them. We set them up and started to see what would happen.
Wow. And what came out, well, one of the things that I heard you say that came out of this is not only just a benefit for patient, but benefit for the provider in a it sounds like a personal way. Yeah. But also one interesting aspect was that you were able to refine your process and define how you are working, with the patients in the process. So can you tell us a little about that?
Yes. So co-delivery, co-production, co-design of care. And essentially we're trying. It's really difficult. It is a big challenge to do this. We're trying to move from doing things for our patients and about them to doing things with our patient, or even getting them to do it for us. And it's difficult, it's slow, but we're asking them to help us not just consult, but design. We have at the moment quite an exciting development where they have offered, our patients, a few of them have offered to come to the wards. We don't quite know how it's going to look yet, but they want to come to the wards perhaps once a week on a Thursday or a Friday, some in an evening to reflect their work patterns. They'll have their CRB clearance, and they're going to come in and meet emergency laparotomy patients who've just had surgery. So to talk about it, hey, look, I've got a stoma too. Yeah. It's okay. I can still wear trousers and dresses, or don't worry, you will poo again. You will have a glass of wine again.
Those are questions.
These are the questions
legitimate.
that matter, and we're not so good at talking about this.
It's uncomfortable.
It's uncomfortable, and we don't know. We haven't got the lived experience.
Yeah.
So that then really would be co-delivery of care. Yeah. And emergency patients, again, are different because they may have only come in very quickly. You don't have time to do that before the surgery. So this is a new area to explore, seeing how it make it work, but importantly, supporting those patients who are offering to do that as volunteers and supporting them through maybe some difficult conversations that they're not expecting to have. So we've got some learning to do around that, but it's exciting to think that it's powerful when someone comes and says to you, I've had that too. I know what that feels like.
And there's good international evidence that sort of approach really is one of the best ways to improve quality across the board. So we know, for example, from studies of US hospitals and UK hospitals, that those that have a kind of systematic approach to engaging patients, who have it kind of built into all the structures, the governance structures, the human resources structures, so that people, that when they're appointing people, they're really looking for people who are going to work with patients rather than do things to them. The board is aware and is monitoring whatever kind of, there may be audits, there may be surveys. The hospitals that really take that seriously are right at the top of the tree, and that's probably one of the reasons why Medway is no longer in special measures, why it's improved so much.
Yeah, that's fantastic. Well, ladies, thank you so much for joining us on Top Med Talk. Those were great presentations. I know everybody loved hearing them, and I did too. So I just want to say one thing that I love about Top Med Talk and when we have the opportunity to sit down with this diverse group of providers and researchers, you learn so much in this international perspective. I've learned so much being here and hearing about the UK processes, and being able to take those back home, I think is really cool and great for our listeners as well. So I think the NHS should be very proud of where it stands 70 years later. And I think on a day-to-day, as a special hospital, it may feel imperfect, but as an outsider, kind of hearing these national projects that both of you are involved with, and so many of people here at EBPOM, specifically about quality improvements, the NHS is really inspiring for us. So I want to thank you guys again, and thank you for joining Top Med Talk 2018, or EBPOM 2018 on Top Med Talk. If you're listening throughout the next 2 days on our live feed, check out slido.com, SLIDO.com. Code EBPOM28 or EBPOM18, EBPOM18, and you can ask questions for the speakers throughout the conference. So thanks again for listening.
Top Med Talk.
Don't forget, of course, you can meet the Top Med Talk team. All you need to do is check out our website, topmedtalk.com, and then sign up for the email updates. As soon as you've done that, you'll find out where we're going to be, where we're going to go, and where we have been. We'll also tell you when we're broadcasting live from the Top Med Talk website. So get yourself there as soon as you can, topmedtalk.com, and sign up for the email updates.